this patient has RD but hypotony. So I already put the trocar. You see the vitreous here. Still, I'm gonna check because these patients you get infrachoroid, so you gotta make sure you are in the vitreous space before you start the infusion. This is very important. So I think I am not in the vitreous space. This is very important. I'm not in the vitreous space, so I am not going to turn on. This is a bubble, but I'm not in the vitreous space. So what I'm gonna do, I'm not gonna turn on the infusion. Point 1, 2. I'm not gonna turn on the infusion. Gonna come out, infusion off. Okay, I'm not. By the way, I have clamped the infusion, so the infusion is still off. So see, it's off. So I'm not gonna go in. So we're gonna change this trocar to 6mm trocar. So I'm gonna come out. Yeah. Okay. So this is. Okay, so hold on. Maybe I'm in the vitreous. 1 second, 1 second. I'm gonna go ahead and do it again. VSS on the cornea. See the cornea. Okay, go ahead. I'm gonna do the. Don't. No, off. So I'm gonna go ahead and see if I can see it. Okay. Yes, I am under the choroid, so still. So I'm gonna come out. This is crucial because it can really mess up your surgery if you don't take care of this issue. BSS on the cornea. We don't want to screw our cornea. We want to make sure we're doing good cornea, taking care of our cornea. It's the window to successful surgery. 6mm. I need the trocar, please. So we're gonna go ahead and remove this again. Even though, see, the the MVR is going inside. Still, I cannot visualize the cannula. See? See, this is see, this is the 6mm. So, okay. Fusion is off. I have to visualize it and then on. See? Now it's on. Now on. Fusion on. Okay, on. Fusion on. Okay, excellent. Okay, see, now we're good. So we're now doing safe. And I think you will notice how because this is a chronic retinal detachment with the hypotony, there's chronic effusion of the choroid, so the choroid is pushed inside. So now we go ahead and enter. The most important thing is the infusion, because when you enter with the infusion and then the fluid will push the choroid inside. Okay, go ahead. Light pipe before we start. Lens down. I just want to see. Lens down. You see the pigment shaver. Yes. Now down. Okay. See the choroid. See, choroidal. Okay. Okay, we're gonna go see the choroidal effusion, choroidal detachment. But see, thank God we are inside. core. We're just gonna do core now. We stay in the center and do core. Okay, sorry, we had some technical issues with the voice recording. So we did a little bit core vitrectomy. Lens down. Okay, so we have choroidal detachment here. Okay, you see there's HPMC, so we cannot touch the lens. So now we try to see if there's any vitreous here. So go ahead. This is any retinal detachment surgery. Try to peel the vitreous anteriorly. See chronic detachment. The patient only says loss of vision for the past 10 days. I doubt this. So the key to this surgery is make sure you don't enter under the choroid. If you don't visualize the trocar, do not enter. So we're gonna use now the PFO to push the choroid. PFO, Bob, already? Okay, so since there's no I did a very thorough B scan for this patient. Make sure this was not a choroidal melanoma, because sometimes choroidal melanoma can disguise vitrectomy. See, the optic nerve is pale when I'm pushing the PFO, parafluorocarbon, so I use the vitrector to lower the pressure. See, pushing both the RD and the choroidal effusion. Okay. Light. Multiple horseshoe tears. Cautery. We need cautery to cauterize this bleeder here. Also to delineate where the tear is. There's another tear, I think, here. Yes. I may drain some of the choroidal here. Decide to drain. To go slow. Easy does it. So I discussed with the patient the high possibility of redetachment and need for further surgery. Okay. So I think this. Usually, I'm able to do surgery even with choroidal effusion is fine, but this is kind of annoying me. So, skull depressor. Light. Where's there's a tear here. Checking there's any tear here. I thought there's a tear here. Looks like a. No. There's no tear, just. Nice if I can. There's the vitreous skirt. I'm shaving the vitreous skirt. Sometimes the choroidal effusion can act like a buccal post-op, which is nice, like for a limited period of time until the pressure goes up and the choroidal effusion goes away. So it actually acts like a buccal, temporary buccal. So it's actually nice until light. Oh, good. Now we removed almost all the vitreous. It's good. There's no other tear. It's nice. Okay, just here a little bit shaving. Light. Clean the lens. BSS. That is bubble come. See, because there's PC tear. Bubble comes to the AC. So I think the reason for this is post cataract complication, surgery complication. Okay. See, this is going. I'm gonna try to go ahead and with fusion. Okay. Give me a trocar. You have a trocar, extra trocar?
Yes.
Give me. Yes. Huh?
6.
No, no, no. Just lights on. Yes. So I'm trying to go under the light pipe and drain 0.12. This is 6?
No.
No, this is. You sure?
Yeah.
Okay, so make sure this is okay. Sleeveless. This is good.
Yeah.
Light pipe.
Right.
So I'm gonna try to drain some of this effusion. Lens down. Because this is where the most. Okay, remove the lens. Lens down. Okay, remove the lens. Sure. Lens down. Light pipe. 0.12. Lens down. See how it's a little bit less. You see? There's a way to. So you see the gush of fluid from the. Scale the pressure. So I'm gonna try to milk. تحمل كذب. Remove the lens. See if it's removing, coming out. See? Good. Yes. Pressure is up. We go up, push the pressure. Extrusion. Let's see. Yes, see, it's coming. It's coming. See? It's coming. This is fusion. This is vitreous fluid, intravitreal, and this is subfusion. Okay, lens down. See, I'm here. There. See the light pipe? Light pipe. See, I'm gonna show you. So we can go ahead and see where we are here. Pressure down. There. You see? which is nice. So gave me a little bit more leeway to do vitrectomy, scleral depressor, vitrectomy. Light. 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 It's crucial to have a 6 millimeter cannula in your surgery room. It's extremely important. Okay, okay. Remove the lens. So now, so you see 0.12. So now when you remove it, some fluid's gonna come out. See? This is also gush from suprachoroidal space. So you just leave it. It will just leak. Like vitrector. Lens down. So it looks good. I think just getting out now and just doing it's good, I think. And then even if he redetaches, you have a better chance of refixing it. So it's good. See, this is not of a high choroidal that you can do the same as what I did with this. There's here maybe a membrane. Okay. 90 lens. Yes, and the ILM. ILM forceps. Lens down. Lens down. Some PVR here. So I think this is the choroidal fold, not the membrane, because I think there may be a membrane here, but there's not. See the choroidal fold? You see? This is choroidal fold. Sorry. Yes, choroidal fold. There is no membrane here. I was thinking there is a star fold PVR here, but there's not. So, but I'm just checking. Okay. There's no epiretinal membrane noted here. Here. This is looks like a flat nevus here. This should kind of resolve with time here. Okay, remove the lens. PFO. Change the lens. push the fluid anterior to the hole. Vitrector. There, it's clean. Laser.
Filter.
Filter on and then off. Yes. Right.
Filter is on. Laser ready 200.
Where's the? Sorry, this I can see. This is the hole we're treating, the horseshoe tear, the cause of this detachment. So this is retinal detachment complicated by hypotony. And that's the reason for the this kind of case. Okay. Okay, extrusion. We're gonna go to air, and then we're gonna drain the fluid. Okay. Go ahead to air. So now, yes, go to yes, yes. So now we go ahead and remove. We remove the fluid first, the fluid, and then we go remove them PFO or perfluorocarbon alkaline, whatever you call it. Yes. Chandelier off. So here, drain. So we're here where the whole horseshoe tear PFO fluid interface, interface, because the fluid was removed, and now so you see there's no fluid, no subretinal fluid, maybe temporally, not nasally, because the 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 temporal fluid cannot go around all the way to this hole. So we'll have some fluid, residual subretinal fluid. That's okay. That should be removed next. See, the reason why our view is so bad because there's a open PC tear. So the residual fluid should resolve post-operatively. Okay, laser. Always treat again.
Laser is ready 200.
remove the lens. See, BSS, Q-tip, Q-tip. BSS, just to clean the cornea. HPMC. A little bit better here. So here. Yes, start the presser. Chandelier on. Lens down. Expecting here. Just here where this. Clean the lens. Just here, I'm suspecting where the superior temporal trocar may hit the retina, so that's why I'm lasering here a little bit. Here, see? Here around the entry. The good thing is we didn't have any iatrogenic tears. So in this case, I think the minimum, the less you do, the better. Because it also makes you live to fight for another day. Okay, chandelier off, light pipe extrusion. Chandelier off. So it looks good. See, this is this should resolve when we put silicone. The pressure goes up. All of it should resolve. Excellent. Looks good. Silicone oil. Looks good. And then maybe you push a little bit extra silicone oil to increase the pressure. This will, and then when the choroid goes away, the silicone oil will be almost full. Because if you don't push a lot of silicone oil, in this case, then what happens, you will have less, not complete fill of silicone oil. I mean, the reason why we're using silicone oil, because there's PVR. I mean, the high risk of PVR, the patient doesn't live close by. So in case he gets a redetachment, we are able to repair it. So we're waiting for the silicone oil now. Okay, silicone oil. Check before we put in. Okay, go ahead. Ventilator, please. The chandelier, please straighten the chandelier. Thank you. Go ahead, remove this. Keep the air coming. See, as soon as feel pressure build, okay, come out. Okay, remove the infusion, please. And then we go ahead using this, we remove the air. Okay. So I'll keep it high pressure. No. Can you remove the ventilator, please? Remove it. Don't worry about it. No, not now. Not now. No. Good pressure is high, so it should resolve in few days. So we went from 20 gauge to 25 and 23. So we don't suture sclerotomies, and apparently it seems like you have to suture all the sclerotomies. Okay, change the 7.0 micro. Yeah. Nope. Two by two. Use the okay. Because when you put silicone oil, it will be on everything. Okay. Good. Excellent. So I feel, see, pressure is can I think go put more silicone oil. This also would be useful to resolve, to make the choroidal effusion resolve. Otherwise you have to use steroids and cyclo, and even when the choroid resolve, I think there will not be a complete fill of the silicone oil. It's really tough to measure. I think it was a chronic RD that he didn't see until the macula was off. And this chronic RD created chronic hypotony, and he didn't notice this until it was too late when the macula was off. And see, what I do here is cut one long, one short, so it's be easier for you. Does it help? Yeah. When you do this? A lot, huh? Yes. Okay, so now we're all secure here. Pressure is a little bit on the high side, which is good because he has choroidals and hypotony pre-op. This will resolve the pressure. No, use the. Okay, so it's very important to wash the other one with the trocar. VSS cannula. Yes. So because we don't want the reaction happens from the silicone oil. No, so we're just gonna wash here thoroughly. It's good. And there's what's cut? What's cut? Time is too long. No, it's fine. Yes, tiny bit here. Yes, wash. Good job. Thank you.